Bismillahir Rahmanir Rahim. Welcome again. This is Dr.KHALED DIAB. I will start with you my second part of my lecture on preterm labor or preterm birth. Part 1 finished with management of women at risk for preterm birth. We will start discussing management of women with threatened preterm labor. As for women with threatened preterm labor, initial evaluation is to assess the benefits versus risks of maintaining pregnancy. The first group of questions is whether we should confirm diagnosis. Is it preterm? Is it true labor? Is labor imminent? That's to say, is there a risk of delivery within 7 to 10 days? Is suspected by either short cervix or a positive cervicovaginal fetal fibronectin. Diagnosed or impending preterm labor is defined as occurrence of uterine contraction 4 per 20 minutes or 8 per 60 minutes with either cervical dilatation more than 3 centimeters or transvaginal sonography with a cervical length less than 20 millimeters, or transvaginal sonography between 20 to 30 millimeters and a positive cervicovaginal fetal fibronectin level. The second group of questions is if there is identifiable treatable cause, which should be treated as urinary tract infection or lower genital tract infection. The third group of questions, if there is clinical significant non-reassuring maternal or fetal condition or a pathology that need termination of pregnancy and contraindicate maintaining pregnancy. The fourth group of questions is to determine the place of care and the possible need of intrauterine transfer to tertiary hospital with better NICU facilities. These questions are answered through the following: classic history, examination and investigation procedures in the clinical medicine. During the face-to-face session, we will discuss how to evaluate a case of threatened preterm labor, and we will formulate an allograft for management. As regards place of birth, OPD care is only indicated for women with preterm labor with a singleton fetus more than 34 weeks and transvaginal sonography more than 3 centimeters length, stable with no significant clinical maternal-fetal pathology, and their home close to the hospital after health evaluation and education. All other women with diagnosed or impending preterm labor should have a hospital admission. This includes those with a significant clinical or non-reassuring maternal-fetal pathology, or those with cervical changes, or those with impending delivery within 7 to 10 days, as indicated by transvaginal sonography less than 3 centimeters. If the diagnosis is not sure, the patient may benefit from a period of 4 to 6 hour observation or overnight admission for observation to confirm the diagnosis. Management includes supportive care, and it also should include NICU consultation is required. Continued maternal fetal surveillance will include maternal evaluation for non-reassuring maternal condition, vital signs, uterine contractions, pelvic examination every 2 to 4 hours if suspected labor progress, fetal evaluation for non-reassuring fetal condition and according to the labor stage. For those women who still not progressed to true labor, they may need re-evaluation of transvaginal sonography for cervical length after 4 days. Possible interventions for threatened preterm labor are tocolysis, 3 measures to improve neonatal outcome, and possible intrauterine transfer. Tocolysis are medication to stop uterine contractions, is only offered as short-term protocols to delay delivery to allow maximum benefit from antenatal steroids to enhance lung maturity. Other indications may be to allow safe transport of the mother to a facility with an optimum NICU care. Furthermore, it may be used to guard women against preterm labor while undergoing surgical procedure threatening her pregnancy. Contraindications for tocolysis are mainly related to the selected therapy used. 6 groups of tocolytic drugs are listed. Choice of drug is related to the gestational age. The student is advised to see reference text for detailed drugs, doses, and complication. 3 main interventions are used to improve neonatal outcome. Antenatal steroid therapy reduces the incidence of RDS, intraventricular hemorrhage, necrotizing enterocolitis, and neonatal mortality by almost 50%. Maximum benefit after 24 hours from the last steroid dose. It is given for threatened preterm labor between 24 and 34 weeks gestation. Repeated courses is not advisable, although a rescue course may be given if more than 2 weeks elapsed since the last steroid dose, or if the first course was taken before 28 weeks. Antenatal magnesium sulfate administration decreases the risk of cerebral palsy and severe motor dysfunction in the offspring. It is limited to gestational age below or equal to 32 weeks, even if emergency delivery is anticipated. Further discussion for antenatal steroids and magnesium sulfate will be done during the face-to-face session. Antimicrobial therapy are not used as a tocolytic, yet it should be used if therapeutically indicated. GPS prophylaxis are given to all preterm labor with a positive GPS culture or should have a known culture state. Therapeutic GPS must be given if intrapartum fever develop. GPS prophylaxis may be omitted if elective preterm caesarean section is indicated with intact membrane. After inhibition of threatened diagnosed preterm labor with a stable patient and reassuring fetal condition, OPD management is suggested. Bed rest is not recommended. Sexual activity is avoided. No prophylactic antibiotic. No maintained tocolysis. Fetal fibronectin testing and home uterine activity monitoring are not useful. Continue progesterone supplementation only if it has been given before. Transvaginal cervical length measurement sonography may be used after 2 weeks. 34 weeks to 35 weeks of gestation is the threshold at which perinatal morbidity and mortality are too low to justify the potential maternal and fetal complication and costs associated with inhibition of preterm labor, which will only result in short-term delay of delivery. Thus, if diagnosed preterm labor more than 34 weeks and the parturient are stable with intact membrane, it may be admitted and labor stimulation started. Yet, if uncertain gestational age or documented or suspicious lung maturity, documented lung immaturity or suspicious lung maturity, parturient should be managed as 32 to 34 weeks gestation. Of course, all unstable preterm labor with significant maternal-fetal pathology should be managed accordingly. Examples are those with pre-labor rupture of membranes or with hypertensive disorders. As regards birth management, you should avoid prophylactic episiotomy or low forceps. Caesarean section or caesarean delivery for preterm babies is only for obstetric indication. Vacuum-assisted vaginal delivery is contraindicated before 34 weeks. Delay cord clamping is advised. Maternal analgesia is guided by maternal need. No need for upper segment cesarean section. Lower segment cesarean section is done, yet avoid small skin incision. Preterm labor with multiple pregnancies or with preterm pre-labor rupture of membranes will be discussed with related topics. An algorithm for management of preterm labor will be revised with the students during their face-to-face session. For this clinical case, the student is advised to prepare and for discussion in the next face-to-face session. Hope this presentation was clear and helpful. The student is advised to read the recommended text and see YouTube links and be prepared with questions and discussions in the next face-to-face session. Thank you for your time.